All right, I have us at high noon here. Please welcome everybody to the UW Department of Medicine Grand Rounds. We have a very special speaker this week, Dr. James Wykowski. He has been my chief resident, one of my 3 chief residents this year. He's been absolutely delightful to work with. He's made many contributions on the diversity, equity, and inclusion front, a topic that he's passionate about. And it's been quite impressive. He's done meaningful interventions, which I think is really most important in this time. I got to meet him 2 years ago, and I've always been quite impressed with a couple of qualities. He's got a really fabulous ability to communicate clearly. He has a bit of theater arts in his background, which gives him a certain dramatic flair and clarity. He's also one of the best listeners that I've been around. He listens very quietly and thoughtfully. Today, he's going to be giving a talk that relates to communication. It's Debriefing difficult clinical events, a universal physician responsibility. And he's got really important things for all of us that work in medicine. And there are many universal lessons that you can extrapolate from today's grand rounds. James is going into pulmonary critical care medicine, joining Dr. Tong, his colleague, also a co-chief medical resident here at the university, in pursuing pulmonary critical care. I tried mightily to get him to go into endocrine, but I failed. He's going to be leaving the Seattle area with his young family. The pride and joy that I think he'll talk about is his son, and he's going to be going to the University of Colorado. Dr. Wykowski, I leave it in your good hands.
Thanks so much, Brad. I'm going to actually first pass it off to Dr. Chen Wu down at the VA, who has a special presentation before we start today.
Thanks, James. And it's wonderful seeing how far you've come since you were my senior resident at the VA, which was just a wonderful time. And I definitely echo everything that Brad has just said about you. And so switching gears to a different, one of our other chief residents, it's been a little bit of a tradition that because the VA is a little bit further distant from the U is, or the UW system is, I for the past couple of years, wanted to take some time to recognize our chief residents here in quality and safety. So this past year was Dr. Carly Williams Silva, and especially because they do touch so much in terms of the GME community up in the mothership, and also they do a lot with the House Staff and Quality Safety Committee. So I just wanted to applaud Carly. She spearheaded what a monumental redesign of the inpatient ward system here at the VA, which was implemented in April. And that has just been a huge change, and really she was the driving force behind it. So thank you to Carly, and we look forward to Yuri being our next chief resident in quality safety, Yuri De Jong, this upcoming academic year. I'll pass it back to you, James.
Awesome. Again, well, thank you all so much for being here. It's really exciting to get to share this talk with you about debriefing difficult clinical events, what I think of as a universal physician responsibility. As today's speaker, I have no financial disclosures, nor do any members of the Grand Rounds Planning Committee. And today, what I really want to share with you is the story of creating a novel debriefing curriculum for our internal medicine senior residents, focused on processing the emotions that often come up after a difficult patient event. We'll go through the background and inception of this curriculum, what we created and how we implemented it, and then some of our data from evaluation. But one of the key parts of making this curriculum was really thinking of this skill as leading a team and setting aside some time to share the emotions and debrief after a difficult event as being a universal skill for all providers, regardless of their specialty or practice environment. And so along the way today, we're going to talk through a few scenarios of difficult events that might come up. And I'll ask you to share your thoughts in the chat so that we can think about how we might respond to them. We're in the Zoom webinar format, and so it might be a little bit difficult or different from what you're used to, where you might not see your responses pop up, but I'll be able to see them and I'll read off your responses to the group. So please do participate. I also want to acknowledge that this project wouldn't have happened without the support of 2 key centers here at UW. First, the Cambia Palliative Care Center of Excellence, who was a big partner and sponsor of our work, and then the UW School of Medicine Center for Learning and Innovation in Medical Education, from whom we were a recipient of a small projects grant that really helped support the first year of our curriculum and make sure that it was possible. So thanks to both these teams for helping us out. So to start this story, I really have to go back to my third year of medical school. This picture is from Jackson, Wyoming, where I did my outpatient internal medicine rotation. And then after that, I returned here to Seattle and to the U for inpatient medicine wards. And it was there one post-call morning around 6:30 where my team was called to a code blue on 6 Northeast. I remember everything about that morning. I remember the palpable anxiety and fear in the room when we first walked in. I remember what it felt like to do CPR for the first time and feeling the patient's chest beneath my hands. And I remember the combination of terror and excitement when I was given the heavy responsibility of being a pulse checker and having my fingers on the femoral pulse. After about an hour, I remember that our team was pulled away because it was our post-call morning and we had patients to see and rounds to do. And so we left and started rounding. About an hour later, my senior resident got a page letting us know that unfortunately, despite all of our efforts, we hadn't been successful. We didn't get ROSC and the patient died. We moved on and kept rounding. And once we were finished, as I was leaving to go home for the day, my senior turned to me and said, "Thanks for all your work during that code. It was really hard. I hope that you get some time to process this experience in the future." And I went home and I took my usual post-call nap, and we never talked about the event again. This was a trend that continued throughout my training. Oftentimes, after a big, difficult event like this, it always felt like the person who was in charge had some sense that they needed to say something or do something to mark the moment and check in with everyone. But it was almost like they didn't necessarily have the skills or the words for what they were supposed to say. I remember being a fourth-year medical student in the emergency department, and after a patient died, a senior resident asked me if I had ever seen a patient die before. And when I said yes, it was as if because I had already been initiated into this group that there was nothing else that needed to be said and we didn't need to do anything else. I also started to feel the cumulative impact of these events on myself and those around me as I progressed through training. I felt myself, as I did more and more rotations and saw more of these things, growing detached from the patients I cared for and less connected to the emotions that you might typically feel. As we went through intern year, my friends and I would often talk about work and the cases that we saw. But even though we were having conversations about the types of things that would be typically thought of as devastating and something you wouldn't talk about in normal conversation, we talked about it in this very detached way without any of the underlying emotion present there. The last thing that really resonated with me was that I often saw this practice from attendings where when they asked us to do something differently when managing a patient or to think about monitoring a problem, they would bring up a really devastating case from the past that they saw that they couldn't forget. In particular, I remember being on my nights rotation and being handed a list of patients to follow and asked to follow up a midnight sodium level on nearly all of them. And when I asked my co-intern why, he explained that their attending previously had had a case of devastating hyponatremia and didn't want to ever have that happen again. So anytime a patient's sodium was abnormal, even if it was just by a point or two, he wanted it trended every 4 to 6 hours until it normalized to make sure they didn't miss anything. I wasn't there from that event or from many of those other events, but I always wondered, what was that experience like for my attendings? What support did they have after the event? And did that impact the way that they incorporated that experience into their future clinical reasoning and decision-making? I was also exposed to a lot of debriefs throughout training, but most of them always were centered on quality improvement. What did the team do well? What could they improve on? How can we make sure that we did better next time? But rarely, even if there was space that was supposed to be for thinking about the emotions associated with the event, did we actually get there or use that space? And so I started to think about the idea of emotion-focused debriefing as a universal skill for physicians. As I entered my second year and the clinician educator pathway, I was required to come up with a scholarly project. And so I applied Kern's 6-step model for curriculum design to this problem we identified of a need for more emotion-focused debriefing training. For those less familiar with medical education scholarship, Kern's is really the gold standard for creating a scholarly approach to curriculum design and walks through the steps of identifying a problem, creating a curriculum around it, implementing it, and evaluating it. And so I'll use this 6-step model to walk through the work that we did on this curriculum. We'll start with the problem ID and needs assessment. So I first looked into the literature about the impact of these critical events on providers. There's been multiple studies of residents after in-hospital cardiac arrests, and about a fifth to a quarter report that after a cardiac arrest, they continue to have traumatic recollections of these codes that impact their mental well-being and their future clinical practice. And another large study of both trainees and attending physicians about recent patient deaths, nearly a quarter had a recent death in the last few months that they reported as very disturbing, that they were still thinking about. And in one of those studies about in-hospital cardiac arrests, more than half of the providers who responded afterwards didn't take a break before they immediately went back to other clinical duties, regardless of whether or not the team got ROS during the arrest. Looking a bit into the literature about debriefing, in that same study looking at how people were coped after recent patient deaths, most of the residents reported talking to another resident after a patient death, and most also did talk to an attending too, and about less than half talked to their spouse or significant other. But interestingly, when asked who was the most helpful to talk to, people were most likely to report that trainees were the most helpful, followed by their spouse, and attendings were cited as the least helpful. Lastly, in looking at sort of existing debriefing formats that were published, most really were grounded in the idea of QI and performance improvement, like I previously said. There were a few that talked about processing emotions as a team, but all of those were led by attendings or by outside facilitators, folks from palliative care or chaplains, not necessarily someone from the team who had experienced the event with them. We took this data to our own residents and did a needs assessment survey to sort of see their perspectives. And overwhelmingly, residents felt like it was the job of the senior resident to lead a debrief after an event like this. But most of them also requested more training on this topic and didn't necessarily feel like they were ready to step into this role, even if they wanted to. When we asked about barriers to debriefing, most people cited time as the largest barrier, which I don't think is surprising, thinking about most of our clinical days. And then some people also reported, again, not feeling confident. And in a minority of cases, there were some faculty already leading debriefs that meant that there wasn't necessarily a role for a senior resident to do it. We also looked around at some of the existing resources that might support a new debriefing workshop. And by and large, the largest resource we had is that thanks to the work of people like Carolyn Hurd, Susan Merrill, and Amanda Shepard, throughout our residency program, we have an embedded skills curriculum for residents. In this curriculum, on the first day of rotations, residents get a chance to be pulled away from clinical duties and practice a skill that they're going to use during that upcoming rotation. For example, here at the U, when people rotate onto the wards with a large number of patients with cirrhosis, they spend about an hour on the first day practicing paracentesis skills that they'll then use to do paras during the rotation. But importantly, in this curriculum, we don't just focus on hands-on procedures like paracenteses, lumbar punctures, and central lines that might come to mind when I say procedure practice. We also treat serious illness communication as a skill. So on the first day of the ICU, interns practice leading family meetings. And on the first day of HEMONC, interns practice delivering serious news. Treating these as skills reminds us that they're not inherent characteristics that some people are good at and some people are bad at, but instead they're things that can be broken down into steps and taught and practiced and improved on the same way as some of these more hands-on procedures. The other real resource that helped support this work was that as I started to meet with more people and talk about the idea, there was a palpable enthusiasm from folks from hospital medicine leadership to folks in our residency program to my own co-residents. And so it really felt like the timing was right to implement something like this. So I'm going to tell you more about the curriculum that we created in a moment, but first I want to take us back to the case that I started with of a busy post-call morning where your team has also just responded to a really difficult code. And you recognize that it's important for your team to spend some time processing that experience, but you also have patients to see and ACGME duty hours to respect and a team who has been in the hospital for a long time already. How might you handle this situation? Love for folks to start sharing their ideas here in the chat. Yeah, great. So I see a lot of nice ideas coming through, maybe thinking about other people who might be able to cover some clinical duties to let your team be pulled away. thinking about scheduling a future time, but acknowledging it there in the moment. And then also recognizing that maybe even with all this going on, you just need to make the time. And so our first pearl really is that timing is a mindset. The reality of most of our days is that there's never going to be a perfect time that arrives to debrief, where no one is asking for anything from you, there are no more admissions to do or patients in clinic to see, and your inbox is perfectly clean. And so really part of our responsibility as leaders is to elevate the necessity of these debriefs, to say that regardless of everything else going on, we need to set aside all that and focus on this for the moment. As a facilitator, practically, this means one thing I try to do is limit participants' cognitive load during it. And so that means either handing off responsibility for things to someone else or holding pagers or signing into the patients myself, so that if other pages or things come up while we're talking, I can do the work of triaging that as opposed to asking the members of the team to do it. And then as many people suggested in the chat, sometimes there's a question of, should we talk about this right now, right after it happened? Or should we allow for some time and do it later? There's not really a one-size-fits-all approach. It depends on the context. I'd argue that maybe in the scenario we described, if a team has been awake for 28 hours, it might not be the best time in that moment. And so if you're going to schedule time later, though, it's always important to try and mark the moment as it happens. Let people know that it's normal to have an emotional reaction and to be still feeling this event afterwards. And highlight that at a future time, we're going to sit down together and talk about it again, so that people know that this isn't something they have to walk away from and they're never going to have permission to talk about at work again. So we're going to move on now to talk about the goals and objectives and educational strategies we designed for our curriculum. We're going to focus more on the strategies for today, just for time, but we did also have sort of rigid goals and objectives that we had designed. So first, we wanted to define our debriefing format that we were going to teach. And we outlined a 6-step approach that was designed to take about 15 minutes, really responding to what we heard about time as a big barrier. There's certainly other debriefing formats that are much longer and intensive, but we realized that that wasn't something that was going to be easily implementable in the course of a typical workday. We then took that debriefing format and created a workshop around it to teach the structure and give the participants a chance to practice those skills with a number of scenarios using each other as models. We then piloted our workshop with a group of senior residents who were graduating and asked them to take the evaluation surveys to get a better sense of if our data was going to be valid. And then we introduced our debriefing curriculum at an all R2 event. So before they all became R2s, all the interns were gathered together and we gave them some time to talk about experiences from intern year, about what support they had, and to think a little bit more about stepping into this role as a leader. And thinking about where to place this in our curriculum, we selected Harborview inpatient wards for a few reasons. First, it's one of the first times residents take on the role of being a senior resident, and so we knew it would be an early chance. But also our needs assessment data told us that this was a rotation with a high volume of these difficult patient events. And so we knew that participants would get a chance to get hands-on practice soon after learning the skills. Thanks to a partnership with Kim McDonald and the excellent hospitalist group at Harborview, we were able to make sure that our participants' time would be mostly protected. So they weren't worrying about getting pages or other clinical duties while they were there, that attendings would be able to step up and be present for their teams so that the seniors would be allowed to be at the workshop. Then recognizing that this model of an embedded curriculum meant that we had to do 13 workshops throughout the year on the first day of every rotation, we recruited and trained additional facilitators to balance the teaching load across the year. I'm going to share more about what we found as we did this, but before I do, I want to take us back to the case. So you went ahead and marked the moment and waited for your team to come back a few days later to talk about the event. And as soon as you do, you find that the team immediately starts to pepper you with questions. Your medical student who has never seen a cardiac arrest before immediately has questions about the ACLS algorithm. They're wondering why you gave certain medications, what makes the rhythm shockable or not, and just why you did what you did. Conversely, your intern is really worried about some of the decisions that your team made and things that happened in the patient's care leading up to the case. They weren't sure about some of the recommendations the cardiology team had made the previous day, and they wondered if that had gone into this. And they noted that some of the medications that were supposed to be given that morning by the nurse got missed in handoff, and wondered if you should file a PSN to reflect that. And so as someone who's starting out a debrief, trying to focus on processing your team's emotions, and then you're immediately peppered with all these questions, how might you respond as the facilitator? Great, so I see a few different responses coming through. Thinking about folks to really highlight that we're gonna start with a pulse check to see how we're doing before we transition into the Q&A. Thinking about sort of maybe separating these two parts of the debrief instead of having them be integrated, and really highlighting sort of the purpose of what you're doing up front, and really framing that the purpose is to talk about emotions. I think this is a common thing that can happen. And so really our second pearl is to think about connecting events to emotion. It's helpful as these questions start to come up to recognize the underlying emotion. And one way that I often think about it is that as a physician and as physicians, we're all sort of trained to be primarily cognitive people. Thinking through problems is our comfortable space, especially as internists. And so it's easy for me to imagine that after a really difficult event, when some challenging emotions start to come up, that the most comfortable thing to do is pivot back to that space of thinking rather than sitting with those difficult emotions. And so it's natural that these kinds of questions about learning and quality improvement might come up first. We train our senior residents to use what we call the parking lot for this. And sometimes that means physically even writing these things up on the board to let people know that we're absolutely going to do a talk about ACLS later in the week, and we will make sure we file that PSN. But before we do that, circling back deliberately to emotion-focused debriefing. It can be helpful as you start to try and talk about these things to have some questions to ask to prompt folks. And they can be things as simple as just asking, how did this event make you feel? Particularly if someone might share a salient thing that they remember from the code or from the patient experience. Another question that can be helpful is, it's normal to feel grief or guilt or anger after a patient death. Does anyone feel like they're grieving? This can feel like a weighty responsibility, but I want to remind you that we often are in the role of responding to our patients' emotions, and we do it all the time. Some people might be familiar with the nurse mnemonic from the Vital Talk resource that is a guide to thinking about different ways that you can respond to patient emotion. An example of a nurse statement that might be appropriate in a debrief is something like, it sounds like not being able to have family at bedside was really frustrating. Recognizing the underlying emotion and something someone might be sharing. This is often going to be the part in a debrief where there may be some silence. And that can be uncomfortable for you as the facilitator who wants to bring people into the discussion. But recognize again that this is something we do with patients all the time when we're dealing with difficult things. We create silence and space to sit together and just feel how we're feeling. Not all emotions need to be verbally discussed. Practically for a facilitator, especially someone like me who is extroverted and can feel uncomfortable with silence, this is when I pull out my internal clock and remind myself to count to 10 or 30 or even 200 if that's what it takes before jumping in. So we're going to move on now to talk about the implementation of our curriculum and some of our evaluation data. So during our initial year, we had 13 workshops that were led by 5 facilitators, and 50 out of the eligible 64 residents participated. Those who didn't were mostly either sick on the first day or were coming off a night's rotation and so weren't physically present that day and able to participate. There were a small minority who unfortunately were pulled away due to other urgent clinical duties, which is one limitation of the embedded format we have. We surveyed our participants before and after the workshop, and then 30 days later at the end of their rotation. And to better assess the impact of our intervention, we also created a historical control group of residents, some of whom were the people who weren't able to make it that first day, and some of whom were residents who did their first inpatient wards rotation at the VA Medical Center. And so we're still in the role of being a team leader and experiencing some of these events, but didn't necessarily get to go to the training yet. And looking at some of the key outcomes from the pre-post surveys of participants, we found significant increases in all 3 of these domains, reporting feeling prepared to lead debriefs, reporting feeling prepared to respond to participants' emotions during a debrief, and planning to lead debriefs during the upcoming rotation. We saw the largest increase in being prepared to lead debriefs, largely because of the low baseline level of competence. We wonder if this higher rate of feeling prepared to respond to participants' emotions may be because many of our participants had already completed some of the palliative care and serious illness communication workshops that I mentioned at the beginning. And many of those skills easily transfer over to the debriefing environment. One really interesting finding is the fact that there is this high level of participants reporting that they plan to lead debriefs at the beginning of the workshop, even though very few of them feel prepared to do so. I think this is a phenomenon that's actually quite common as physician leaders and as residents, where you're asked to step into a leadership role without a lot of dedicated training on specific topics that might come up as a leader, and you sort of figure it out as you go. And the historical controls helped us better explore this. Because I'm looking at 30 days of follow-up, wondering if whether this is just a skill debriefing that you'll figure out as the rotation goes, we found that our workshop participants were much more likely than the controls to report feeling prepared to lead debriefs at the end of their rotation. There was not a significant difference in feeling prepared to respond to emotions, just in feeling prepared to lead. Another outcome we were really curious about was feeling like you had enough time to debrief. We knew this was a big barrier from the outset, and so we wanted to explicitly target this. Through giving this model of a 15-minute debrief and talking about ways to prioritize debriefing, we were able to increase the proportion of folks who felt they had enough time at the end of the workshop. But still, at 30 days follow-up, more than half of the participants reported time as remaining the largest barrier to debriefing. Taking our data all together, we overall felt like our residents' self-assessed debriefing skills improved in several domains, that we were able to mitigate but not necessarily eliminate time as a barrier, and that clinical experience alone was going to be insufficient for residents to learn debriefing skills. I want to take us back to our case one more time. So as you're moving through your debrief, you find that your third-year medical student is very tearful during and after. This is the first code they had been to and the first patient death they have seen. And they continue to be very tearful and withdrawn, a big shift from how they had been for the rest of the rotation. Your intern, on the other hand, continues to really perseverate on some of the decisions that were made coming into the case. They're frequently chart checking. It seems like every time you come into the room, the patient's chart is open and they're reviewing specific details. How might you respond to these different reactions in your participants? I see a number of really nice comments in the chat. A bunch of support for thinking about individual check-ins with people beyond sort of the group discussion. And then thinking about having a spirit of curiosity and sort of trying to understand, you know, what is in the chart that you're looking for? What is it that you're still worrying about, or what's staying with you? And then also thinking about maybe the scope of support that someone needs and whether or not they need more support beyond what you can offer. And then maybe sharing some things that you might do to be helpful. So this brings us to our last pearl, which is really that debriefing is just the beginning. We can't expect to address all the emotions and all the things that may come up in a 15-minute debrief after a difficult event. So it's normal that your participants might need additional and differentiated follow-up depending on their experience, their level of training, and other things that may have happened to them in life. Part of a debrief can be helpful to normalize different coping strategies and resources that are available to participants. So here we prompt our students and residents to remember that there is counseling through GME and through the School of Medicine available to them, that many people find it helpful to talk with their peers or with family members and friends, and that this is a normal part of responding to an event. We also recommend the UW peer-to-peer program as another source of support available to all people who are here in our system. This is also a reminder as a facilitator to consider your own needs. Part of the debrief may be helpful for you to share your experience and be a part of it, but you might need unique things yourself and may need to talk with people outside the group too. There are some exciting future directions for this work, in addition to continuing the training happening for our residents rotating on Harborview wards. We've had some hospitalists come and join for the training, and we're excited to think about expanding it to more attendings. We also did the workshop in a virtual format at the SGIM regional meeting last year and had a number of attendings attend, many of whom work in an outpatient setting. And it was interesting to see how this workshop can still really work for people who practice primarily in an outpatient environment and have different but still very important difficult events happen. We've written up our preliminary findings with the manuscript submitted for publication. We've also thought about other specialties who may benefit from this training, recognizing that these types of events are not unique to internal medicine. Some other areas of interest that we're considering looking at next is really this area of difficult patient outcomes. We gathered some exploratory data where we asked participants about the easiest and most difficult types of events to process. Overwhelmingly, our interns responded that adverse patient outcomes, more so than deaths or codes, were the most helpful things to debrief. Times where a patient had an outcome that just wasn't what you would wanted, where maybe you worried that something you did was a part of that, but also where things just ended on a note that wasn't what you would want. When we asked senior residents about the easiest and most difficult events to debrief, they also said these adverse patient outcomes were the most difficult things to debrief. I think that speaks to an experience that is common as we progress through our careers, where over time, a discrete event like a code or an expected patient death for someone who's already on hospice or comfort-focused care pathway might not be as impactful long-term as these cases where we worry that something didn't go the way it was supposed to. And those are the cases that keep us up at night and that we're still thinking about, and that we might need a different kind of debriefing to work through. I also wonder about the impact of these events on people's clinical reasoning. We think about clinical reasoning as a cognitive process primarily, but if it's really the combination of our prior training and prior patients that we've seen, and some of the most impactful patients are the ones who end up with these difficult outcomes, I wonder about how processing the emotions associated with those outcomes might impact the way that we then apply those scenarios in future cases. As we wrap up today, I want to remind us of some of the key takeaways for debriefing that we talked about. First, that timing is a mindset, and it's our role as a leader to elevate the need for debriefing to be equal with many of the other responsibilities we have and to share that value with our team. To think about really connecting events that happen to emotion using silence and some of the key prompts that we talked about. And then lastly, to think about debriefing as really being the beginning, and that we won't necessarily get through everything that we're feeling or everything that we need with a 15-minute debrief, but that it can be the start of a conversation and a start of changing a culture. I want to end by highlighting that this work is really challenging because it requires us to confront that most of us trained in a culture and an environment that implicitly or explicitly told us that emotion was not supposed to be part of our jobs, that we should be primarily cognitive physicians who experience these difficult things as a normal part of our job and move forward and just keep going. But it's also really exciting because it means that we get to be part of creating a better culture for ourselves and for future generations of physicians. I've always thought this work was important and why I created this curriculum. And yet, even over the course of my own training, I found the cumulative weight of these events starting to weigh down on me and feeling myself be more and more detached from patients, and that many of the practices I knew were important weren't things that I was personally incorporating on a day-to-day basis. What changed things for me, though, and reminded me of the importance of this was that at the end of my residency, I became a parent for the first time. And meeting my son and holding him and spending time with him, and then starting to think about coming back to work, it was abundantly clear to me that my priorities had shifted, and that no matter how important being a physician was and how it was a core part of my identity, the most important thing in my life was to be able to come home and be the best version of myself for my son. That didn't mean always giving 100% of myself. Sometimes that's just not possible depending on what happens, but whatever I had to give, he deserved. We're not all parents, and it shouldn't take becoming a parent for all of us to realize the importance of this work. We all have people and things in our lives that give us meaning and that we care about and who deserve the best version of ourselves. Ultimately, this is also about caring for ourselves and recognizing that even though we do a lot of work to care for and be with other people, that this is something that we deserve and is worthy. So I'm really excited to get to continue this work, and I really appreciate all of you for your time and your willingness to come on this journey with me. I really believe that together we can make a better culture for ourselves and for the future. So thank you so much. I want to just acknowledge that this work would not be possible without a Herculean effort by a number of people. Susan Merrill, Katie Hicks, Lindsay Gibbon, and Trish Critic were all key parts of the creation of this workshop and implementation and ongoing support. Gabby Berger was directing the clinician educator pathway and really encouraged this idea, along with my co-residents in the pathway who were there for this initial spark. And then Amanda Shepard, Ken Steinberg, and Kelly Corning have been really key partners in the internal medicine residency program to help support this. Lastly, Randy Morrison, Laugos Sokol Hessner, Anna Hagen, Tim McDonald, and Bob Harrington at Harborview have all been big supporters of this, some as facilitators of the workshop and otherwise making sure that our participants have the chance to attend as a part of their rotation. Thank you all so much for your time. If you're interested in learning more, as Dr. Annawalt mentioned, I'll be leaving UW soon. So this is my personal email and would love to hear from you. And then Lindsay Gibbon, one of our faculty members here, will be taking over responsibility for this training moving forward. And if you're interested in getting involved, your email is here on the screen.
James, that was a great talk. I will tell you that you got many accolades in the chat, and you got accolades for your presentation. And then the internal medicine team C wanted to comment on how cute your baby was too. I have a couple of questions about the presentation itself. If you don't mind, I don't need you to go back to the slide, but if we can return to that scenario where you've arranged a debrief and you have a medical student who is sobbing and an intern who is looking at the electronic medical record on a regular basis instead of looking at other people. Do you mind actually walking through how you might have managed that? Because to be candid, that was a pretty tough scenario you described. You've got somebody who is expressing a lot of emotion, and another person that is distracted, and we don't know the etiology of the distraction. Can we start first with how you would interact with that intern that is spending time on the electronic medical record? I mean, give me an example of how you might address that, you either directly or indirectly. Maybe you mentioned normalizing coping with grief. How would you address that scenario that you gave to us?
Yeah, thanks so much for the question. I'm actually going to flip it a little bit and take kind of in that moment. I think when you're there in that room, I think your first priority has to be the person who seems to sort of be the most vulnerable and suffering. And in that moment, it probably feels like that's the MS3 who is just really distraught. And so I
was trying to give you the easy one first. Okay.
And so I think in that environment, your first reaction is really to turn your attention to them and make sure that they feel supported and cared for, and that the rest of the conversation doesn't really need to move forward right then, that sort of their needs and vulnerability in that moment is the most important thing. To recognize that they are feeling probably a lot of different things, and maybe it's no longer the time to be talking a lot, but just to sort of sit with them as they're grieving and letting them know that that's okay, that it's a comfortable space, that the way that they're feeling is totally normal, even if other members of the team aren't sharing their emotions in the same way that they are. I think for the intern, they're likely in a different space than the medical student and thinking about the event in a different way. And so it really lends itself to follow up at a different time when it's just the two of you. And sitting down and letting them sort of maybe sharing what you notice. They're often checking the chart and wondering why that is, and coming in with a spirit of curiosity. And then maybe inviting them just to try and probe and see if there's underlying emotion there that they're not expressing, or if there really are specific things that they're worried about where you can maybe put their mind at ease or help them understand why certain decisions are made. I think these situations are really challenging because the cognitive and emotional domains are so intertwined that it can be hard to tease them out. And we try and do that in this debrief, but pulling them aside and working one-on-one might be more fruitful in this case.
Just to ask a few more questions on that scenario, because I thought it was a very difficult one. And I appreciate your attentiveness to the person who's distraught. That seems like the right person to address immediately. Can you set the stage a little bit? Would you declare that we're going to be quiet just for a moment, or would you just simply be quiet? And the reason why I ask is, you're part of this is an effort to role model and educate. So one might just simply role model being quiet, or you might have to give basically a shy run to everybody that we're gonna absorb the emotion here for a minute and not talk much. How would you approach that? Is there a better way?
Yeah, I think there's a few things you can do. I think I would start by sort of just modeling that and sitting in the silence. And I think often when you're in the facilitator role, if that's behavior you're mimicking, that other people will sort of look to you and follow what you're doing. It can also be helpful, especially if you know that you have someone who's going to be someone who shares all the time and feels really comfortable, to set the stage as you're introducing debriefing with some sort of ground rules or ground ideas. And one that I often say is to step up or step back. And so that if you're a person who feels really comfortable sharing, maybe consider creating space for other people to share first. And if you're someone who maybe is quieter and doesn't always feel comfortable sharing, to think about challenging yourself to step forward and share something. And setting that tone from the beginning can help people be attuned to sort of making sure that they're listening to the needs of the whole group and not always just sharing their own experience.
And then just one more follow-up question on the medical student who's distraught. Do you think that it's important to probe deeper or follow up and make sure that this is focused on the trauma of that event, or, this could be uncovering of something deeper?
Yeah, absolutely. I think it can be difficult because we don't want to pathologize right away. Like if you watch someone die, it is normal to be crying after that. We might not always act like it is in medicine, but it is and should be, and we should allow for that. But at the same time, it can be helpful to give yourself a note to circle back and say, I noticed that you were really upset the other day. I wanted to just check back in and see how you're feeling now, and see if there is some underlying situation that might be helpful to check in more about with them, or to think about some other resources that might support them. And so I think from the jump, not necessarily immediately saying, oh, they're crying, so something's wrong, but giving a chance a little bit later to come in with that same spirit of curiosity to maybe understand if there's something else underlying it.
That's great. I know this is an opportunity for others to ask questions in the chat, but I have at least two more questions I want to ask you. Is that okay? Oh, I see a question from Dr. Kersey. Any thoughts on how to incorporate debriefing into procedural subspecialties, for example, cardiology, where adverse patient outcomes oftentimes feel like more of a direct consequence of an action or error by a trainee or others?
Yeah, absolutely. I think this is one of the really tough tensions of our job, that this is a normal part of of things that we do, that if you place 1,000 central lines, that there will be a complication from a few of them. I think some of this work starts from the beginning, where this is a norm that people talk about complications that they had from the beginning in a way that is open and accepting. And I think for example, the M&M conference that we do at Harborview, I think is a really nice example of this, where residents can present difficult cases and things where maybe their decision-making was part of it, and are met with a spirit of support first and understanding. And then only after that's addressed, a chance to maybe think about how things could have gone better the next time. I think this is something I'm thinking about as I become more of a proceduralist next year as a critical care fellow. But I think the other thing too is that having these structured environments where people can talk about them as sort of a pre-planned part, as opposed to something that just only needs to come up when an event happens, normalizes that this is something that will happen, not something that is sort of an anomaly of someone doing something wrong, but in fact, just something that we sign up for when we do procedures, that sometimes things won't go the way that we wish that they did.
That's wonderful. Dr. Kersey, if you have any follow-up questions, feel free to put them in the chat. What you focus nicely on how to improve the skills and the confidence of the residents in leading these debriefings. Do you have recommendations for how we attendings should behave differently? You mentioned that we're the least useful, and everybody that's watching this is either an attending or going to be one day. So what should are there one or two pearls that we should be thinking about?
Yeah, I mean, I think all the pearls that I shared today definitely apply to attendings too. And They didn't gather any more data as to why people felt attendings weren't helpful. But I wonder if it might be because that they are a little bit less connected to the resident experience necessarily and what people were going through in that moment. So I think really trying to pause and have empathy and think back to what it was like the first time something like this happened, even if it's happened to you many, many times since then, and to really be connected with the resident and their experience, and then to really have a sense of curiosity. I think when you have been through something a number of times, it's easy to just sort of imagine what someone is thinking and assume that it was the same way that it was for you, but really being open to the diversity of experiences people might have, and that their reaction might be a bit different than what you experience can be helpful.
And then I do have one last question for you. You've done this wonderful research project this year in educational intervention. You measured how people feel about doing debriefings, how they might manage time and actually run them. But one of the desired outcomes is how the residents feel and perceive these debriefings going. In other words, so do you have thoughts on how you might measure the outcome of how these debriefings are perceived by the people participating in it, and whether there's a gain of skills in that direction?
Yeah, so we did, in some of the sort of exploratory end of rotation data, we did survey interns and medical students who reported feeling comfortable participating in debriefs and reported that they thought it was a helpful way to process emotions. So it felt like it was at least an acceptable intervention for them. But I think we're thinking more about impact of these events on participants now that we have sort of some proof of concept that we think the training at least works for participants to improve their skills. I think honestly that one of the challenges is that these events are really diverse in terms of what happens, and their impact is also diverse depending on participants' experience. And so one thought that we have is to think more about sort of gathering some qualitative data about people's experience after events to better sort of capture what that is like, so that then we can maybe think about targeting our interventions a little bit more based on the type of event that happens.
James, I'm going to give everybody a minute to see if they've got anything else they want to add in the chat. I'm counting to 10. Dr. True has said, thank you for an outstanding talk. So I will join the accolades. That was terrific. Thank you for a spectacular year as one of our chief medical residents and an important leadership role. It's just been really terrific. And congrats again on your family addition and your next adventure.
Thank you. Thanks, everyone.
All right.
Have a good rest of your day.
I'll wish everybody a wonderful weekend, and Monday, Juneteenth.